greater introduction of more treatment options that provides a more nuanced discussion for patients. So, in specifically the large cell lymphoma patient population, we have CAR T-cell therapy, which, globally is still a bit of an access issue. And even within the US, with the full approval of multiple CAR T products, we still have access issues where, majority of the country's patients aren't able to get the CAR T-cell therapy. So that opens up a window for other immunotherapeutic options to hopefully fill the void. Within that space, we have primary refractory patients, which, thankfully for the NCCN guidelines, we have options like the STAR-GLO regimen, which is glofitamab and gemcitabine oxaliplatin. We have epcoritamab, gemcitabine oxaliplatin. And then we have now likely the SUNMO data, which is mosunetuzumab and polatuzumab. So in these contexts, we can utilize what patients may have received in the frontline setting. Again, patients who have previously received polatuzumab, we have the GEMOX-containing regimens. And for patients who have not received polatuzumab, or for those who may be more frail or not fit for chemotherapy, we have mosunetuzumab and polatuzumab in that patient population. Thereafter, if the patient actually makes it past the third line setting into the third line space, we also have the options of single agent bispecific antibodies for which we can utilize. So I think as we get more clinical data, more long-term follow-up, especially for the single agent bispecific antibodies, it'll provide us more information to help us as we sort of conceptualize what to do with these patients. Again, in some of these patients, even if they can't get the CAR, if long-term data from the single agent bispecific support the possibility of cure, then that gives us hope with these early line patients that, again, if they can't get CAR, but they can get a bispecific plus or minus another agent, and they have durable responses past a certain point, we can say these patients are cured as well. And again, allows us to, again, save a portion of the patient population for which we've struggled with in the last several years, especially, as I mentioned, because of the inability of or refusal of some patients to go to CAR T-cell therapy due to logistical requirements.